Next speaker is Professor Helen Cross, who's speaking on behalf also of Timothy Barrett and Daniel Hawcutt. So welcome to Professor Cross. Thank you.
Thank you very much, and thank you for allowing me to come and speak today. I'm here as coordinator of the European Reference Network for Rare and Complex Epilepsies. As everyone will know, the European Reference Networks for Rare Diseases were launched in March of this year. And our particular network has brought together 28 centres across 13 countries with the primary aim of improving the diagnosis and management of the rare and complex epilepsies. I'm also here on behalf of the Royal College of Paediatrics and Child Health in the UK, including the British Paediatric Neurology Association and the paediatric theme of the Rare Disease Network in the UK. So what we want to highlight at this time is that epilepsy is not a single diagnosis. Epilepsy is the tendency to recurrent epileptic seizures. It's a symptom for which there are many different causes. So the epilepsies, as we more accurately now describe them, are being increasingly recognised as a group of rare diseases, and indeed there are more than 130 diseases listed on Orphanet with epilepsy as the major symptom. Many of these rare epilepsies have an onset in early childhood, with a relatively poor prognosis both for seizure control and neurodevelopmental outcome. And one example of this is Dravet syndrome, a syndrome where there is seizure onset in the first year of life, usually prolonged seizures in a previously developmentally normal child. Within the second year, the development of further seizure types and a plateau in neurodevelopment with very little progress subsequently. So their IQ appears to drop, as that's a measure of their intelligence relative to their peers. Despite increasing diagnoses with regard to underlying cause, Dravet syndrome is due to a genetic cause, and the understanding of the range of epilepsies, there is still a need for us to use relatively non-directed treatments at the underlying cause, namely our broad-spectrum anti-epileptic drugs. Electroclinical syndromes, so syndrome diagnosis looking at the seizure types and the EEG, is still useful for deciding on management. Many of them are age-related in their onset, they come on in childhood, and it gives us information with regard to prognosis, both with regard to likely remission of seizures prior to adulthood, and indeed seizure control in the longer term, and neurodevelopmental outcome. Valproate remains one of the most effective anti-epileptic drugs in many of the early onset epilepsies, as a broad-spectrum anti-epileptic agent. For example, one particular syndrome, myoclonic-atonic epilepsy, this particular epilepsy comes on between 3 and 4. Valproate is likely to be the first line and may have a good effect, but there's a 75% chance of remission within 3 to 4 years and medication being weaned. In others, such as Dravet syndrome, as I've already mentioned, there is little chance of seizure remission in the longer term, little chance of independent living in the longer term, but valproate is one of the medications that will give optimal seizure control. Other rare diseases where epilepsy is not a feature, for example, something called Wolfram syndrome, where there's diabetes insipidus, diabetes mellitus, no epilepsy, but optic atrophy and deafness and congenital syndrome, there's no available treatment. And the mechanism of action of valproate supports repurposing in clinical trial situations for active intervention. The concern we have at present is that the current perhaps guidance suggests that no women who are of childbearing age should be prescribed valproate. And this would be to the detriment of many young girls and older women with complex epilepsy, for which a pregnancy would not be an immediate concern. So looking at the questions, what is our view of the risks of taking valproate during pregnancy and its effect on the child? We're very aware that valproate has been proven to cause problems for the unborn child in a proportion of cases, as has already been outlined today. And the risks should be outlined to women at risk for their choice, and valproate should be avoided in pregnancy where possible. When it comes to views on the measures currently in place to reduce the risks of using valproate during pregnancy, we absolutely support the measures that are in place to minimise that risk to the unborn child. but the concern is the applicability or relevance of this to certain populations. In young children, valproate may be the most effective option in syndromes that are age-dependent, of which there is a high chance of remission in the longer term, and hence the possibility of wean. Others with more complex epilepsies, for which valproate in combination with other medications may be the medication of choice to optimize seizure control. The risk of not using the medication may outweigh the risk of pregnancy, or indeed the possibility of any understanding on the part of the individual. Looking at what other measures should be taken to reduce the risks of valproate during pregnancy, we agree that there is a need to ensure women are fully informed of those risks and valproate avoided in pregnancy where possible, and advocate the avoidance of new prescription of valproate in newly diagnosed teenage girls if possible. However, we would encourage the discussion of the longer-term risks of the epilepsy itself and possibly change of medication in teenage girls able to discuss this appropriately, for which pregnancy may only be a consideration in the longer term, although there's still a need to realise they may still only be the medication that leads to control of seizures. However, there is a need to consider whether specific populations for which there is a need for a different approach to be taken, considering the age of the individual, the epilepsy syndrome, previous trials of medications, and associated disabilities, and certainly include the use of age-appropriate information for the young. In summary, valproate continues to be a useful medication in the rare and complex epilepsies, certainly in some of the early onset epilepsy syndromes with a high rate of remission, as well as a potential repurposed therapy for rare diseases with no other treatment options. We need to consider the relevance of guidelines to certain populations and not hinder utilisation in such circumstances. On another note, however, to conclude, the delivery of epilepsy care in children and young people has changed over the last 2 decades. Within the UK, the development of regional epilepsy networks, specific training for paediatricians in epilepsy, specific posts for paediatricians with an expertise in epilepsy, and national standards of care for patients with epilepsy. And when we look at Europe, the European reference networks were designed with one of the purposes of which to enhance the diagnosis and management of rare diseases. And one key aspect of that is education and training and harmonisation of guidelines across the European network. And that is something that we are really tackling within the ERN EpiCare for rare and complex epilepsies. Thank you.
Well, thank you, Professor Cross. So that's a call to